Mickey, let's talk a little bit about the surgeon's role here. Quite a controversial area. This is a 3B case, so I don't think there's any role for surgery here. But if we were to back this up to a 3A, and we're still talking about stage 3, opportunities for surgery. We've had some data showing a potential benefit if you can get a lobectomy, not a pneumonectomy. Can you talk to us about your approach in these patients and your involvement?
Sure, Ben, thank you. So again, I think it's important to separate N3 disease from N2 disease. We have stages 3A, 3B, and 3C, but I still think we just not operate on the N3s and look at the N2s. With regard to N2 disease, there's some soft data. It's not hard data. As we know, it's so controversial, but multi-station disease usually doesn't fare well with surgical intervention. I think they should probably get definitive chemoradiotherapy. Others would disagree because there's really not a lot of data with that. Other soft points are bulky nodes, and that can be defined as either greater than 2 or greater than 3 centimeters. I really look anatomically, if it's sitting on the pulmonary artery, those big nodes, and they may need a pneumonectomy, that I would probably not operate on them. One other thing would be extracapsular spread. So I would say the most conservative people, if they have multi-station disease, bulky lymphadenopathy and or extracapsular spread in those mediastinal nodes would probably not involve surgery. Certainly single-station disease without bulky nodes, I think, can be considered for upfront chemorads with the lower dose of radiation. Typically, I like to ensure the mediastinum has been sterilized. I typically don't like operating on it when the mediastinum is still involved. I think they should just continue radiation without interruption and not undergo surgical resection. But in an isolated case of minimal disease and PET and potentially a repeat EBUS, although we know the results from repeat EBUS aren't as good as regular EBUS, I would consider that group for surgical resection.
Lonnie, any comments on that, repeating EBUS, making sure, do you get these referrals? I mean, this is a contentious issue. Sterilizing the mediastinum, do we need to make sure that that's sterilized before surgery? Is this something that you, as interventional pulmonologists, you get involved in?
We do, and as Mickey said, the EBUS restaging literature is certainly has a lower overall tissue acquisition yield rate. But the minimally invasive component of the procedure and still pretty high rate of achieving a diagnosis, I think warrants it to be a reasonable first step to look at these patients before more invasive testing.
So the patient has gone through the journey, tissue procurement, pathological assessment, a surgical evaluation. They're seeing the radiation oncologist, and then, of course, the medical oncologist becomes very much involved in this case as well. Isabel, you want to talk a little bit about a fit patient with stage 3 who's going to get concurrent chemoradiation, chemotherapy, your options, what you use for chemotherapy in a stage 3 patient?
Sure. Thank you, Ben. I think one of the main things that I think about is obviously underlying histology, performance status of the patient, and underlying medical comorbidities. Because while there are many NCCN guideline approved agents that we can use, one size does not fit all. So I think something that I've found myself using more commonly would be a weekly carbotaxol regimen in partnership with my radiation oncology colleagues, Anshu. One thing that I like about a weekly carbotaxol regimen is that it offers the opportunity for frequent follow-up and check-in. So these patients that may need hydration, they may need a little bit extra TLC. They may need a nutrition consult when they didn't initially. They may have esophagitis that may not get recognized by my radiation colleagues or may have been missed over the weekend, some complications. I think it allows for more frequent follow-up and more comprehensive care.
Yeah, I would agree. I think that we've moved, and we'll talk about Pacific in a second, the data that's kind of changed practice for stage 3. I was brought up in a world where, you use cisplatin always for curative intent patients, and I still at sometimes try to do that. I think for a very fit patient, we try to get, and in fact, if you look at the NCCN guidelines, we try for cisplatin, but I'd say the majority of the time, we've been defaulting, and default's probably the wrong word, to weekly carbotaxol. It's a well-tolerated regimen. It's weekly, and as you said, it can certainly allow for an opportunity to check in on patients at a weekly interval. I've been using some cisplatin pemetrexed for my adenocarcinoma patients. The standard still, if you want to be an academic purist, is cisotopicide, the SWOG regimen, and that is not an easy regimen to give for patients with stage 3, especially when you're thinking about what you're going to give these patients on the back end.